after the lunch break. I would now like to call upon Dr. Amitava Mojumdar on stage for his session on management of CNS infection. Dr. Mojumdar is Professor, Department of General Medicine, VIMS. Sir, request you on the stage, please.
Good afternoon, ladies and gentlemen. It is my privilege to speak on this platform, especially in front of our said Professor Sukumar Mukherjee. And I have been entitled to speak on CNS infection. CNS infection. At the outset, I must disclose that I am a physician who practices a little bit of critical care. I am not a neurologist. So I'll be speaking on CNS infection. Especially, I'll try to focus on acute infections. And Dr. Prabuddha Mukherjee has requested me to keep it case-based. So, CNS infection, as you know, is a very common infection, not a very common infection, but it bears high mortality. So, I am supposed to cover all these things: meningitis, encephalitis, myelitis, radiculitis, SOL, or in combination. SOL, I mean brain abscess or empyema. So, I'll try to emphasize on meningitis and encephalitis and acute infections mainly. So, how do I approach? When I see a patient in emergency, patients with meningitis and encephalitis have similar symptoms like deterioration of consciousness and or seizure with fever. In this scenario, we have got three possibilities: encephalitis, meningitis, and meningoencephalitis. If meningeal sign is present, then we call it meningitis, or it may be combination of encephalitis, meningitis. Before we go into the diagnosis, we must rule out encephalopathies and mimickers. What is encephalopathy? Encephalopathy are all these symptoms: deterioration of consciousness occurring due to global cerebral dysfunction due to some systemic stress. And encephalitis is direct invasion of the organism within the brain. So we need to exclude hepatic, renal causes, hypoglycemia, hypernatremia, decay, demyelinating causes, ADM, SLE, CNS vasculitis, Behçet's, Apla's syndrome, etc., and vascular intracerebral hemorrhage, stroke, SOL, MATES, cerebral subarachnoid hemorrhage, alcohol and drugs, NMS, and the antipsychotic drugs. Now, coming on to the meningitis, this is a classical triad of fever, headache, and neutral rigidity, which comprises out 44% patient presents with this, and 95% patient presents with 2 out of 3 symptoms. 75% presents with decreased level of consciousness, and 25% with seizure, either focal or generalized. And some patient presents with raised intracranial pressure, deteriorating consciousness, papilledema, dilated reactive pupil, 6-nerve palsy, and Cushing's reflex. Now, coming to the scenario, 36 years of male presented to ER with a history of fever, headache for 3 days, and confusional state 1 day. On no history of convulsion, focal neurological deficit was on, papilledema negative, no papilledema, GCS 12, neck stiffness present, and CT brain normal. So, what do you do from here? Then we take the detailed history, and thereafter we do the CSF study. And here high opening pressure, color is turbid, protein is 180, glucose is 20, random blood sugar glucose is 156, cell 1000, neutrophil, and we get gram positive cocci. So this is a classical presentation of acute bacterial meningitis, pyogenic meningitis. So few questions that needs to be answered: whether LP to be done before neuroimaging. Before the advent of CT scan, it has been noted that many of the patients are dying after doing LP. And when the CT scan came, they found some features of raised intracranial tension like effacement of the sulci and basal cisterns, and they realized that these are the patients who are high risk of coning. So this debate persisted in USA for a decade, from 1980 to 90, whether LP should be done before or before neuroimaging. Now, so they have come out with the recommendation that when we can do LP without going for neuroimaging, if there is no convulsion or focal neurodeficit, no papilledema, GCS is more than 12, and patient is competent and there is no quiescence reflex. So which neuroimaging is preferred when the patient is sinking and very, very serious? It is better to do CT scan first because it takes hardly 10-15 minutes, and eventually this patient also might require MRI later on. So why do you do CT scan? To exclude other differential diagnosis of encephalitis like SOL, subarachnoid hemorrhage, stroke, etc. To exclude raised intracorneal pressure and to detect complications of meningitis like brain abscess, empyema, etc. Then we have to take the history regarding the duration of the headache, nuchal, and we have to vomiting, convulsion, and we have to find out whether there is focal neurodeficit or any history of head trauma or neurosurgical intervention, or you have to look for any features of raised intracranial pressure. And other histories like organ-specific histories, like a patient may come with pyelonephritis and may have gram-negative meningitis. Patient may come with pneumonia, may have streptococcal pneumonia meningitis. The history of skin rashes is very important. Why? Meningococcemia. It may present with septicemia, meningitis, encephalitis, and it's an emergency. Patient might deteriorate within hours. So start with the antibiotic, then proceed for evaluation of the patient when there is suspicion of meningococcemia. So other risk factors like HIV and other IV drug user, multiple sexual partners, and we have to find the other immunocompromised states, like whether it is a post-transplant patient getting chemotherapy or having hematological malignancies, etc. So then we exclude the other causes of encephalopathy. It is not possible to exclude all causes in emergency. You have to do some routine examination, X-ray, blood test and other things, and we try to rule out the encephalopathies. Then we, of course, we take care of the ABC. Routine blood investigations are sent, and don't try to forget to take a pair of samples of blood culture, because in many occasions when there are signs of raised intracranial tension, you cannot do LP because of these issues, and you have to start empirical antibiotic and antiviral. So about the need of and about the institution of antibiotic, it has been seen that if there is delay in institution of antibiotic, there is increase in mortality. So the antibiotic should be started at the very onset, and the selection we usually try with ceftriaxone and vancomycin, and at times antiviral also may be considered. Then I was searching for the guideline, Indian guideline, so I found that Ministry of Health and Family Welfare has come out with the sepsis guideline, but there is no guideline on CNS infection. So this is an American guideline in which we usually follow. In our country, where penicillin is not readily available, so we use third generation, fourth generation cephalosporin, vancomycin, amitrozole, etc. So, and it all depends upon what is the age of the patient, and extremes of age, different organisms, and then also whether it is a nosocomial meningitis or it is a community occurred meningitis. So like a patient with ear surgery or may have meningitis, so we know that there is chance of anaerobic infection. So we have to add metronidazole. And the recommendation for neurosurgical, post-neurosurgical meningitis is also different. And we also want to know whether the patient is immunocompetent or immunocompromised. So here we can see that below the age of 1 month, ampicillin, cefotaxime, and immunocompetent patient, usually adult patient, we start with ceftriaxone plus vancomycin. Above the age of 55, because Listeria monocytogenes has to be addressed, so ampicillin is added. And then hospital-acquired infections, ceftazidime and meropenem, and we have to add vancomycin. So here there are list of other organisms where we need to address according to the sensitivity pattern. What we only want to say about the MRSA is that once the patient we diagnose that having meningitis due to MRSA, repeat the CSF after 48 hours, and if it is not sterile, then we have to start intrathecal or intraventricular administration. Otherwise, for 21 days. And other things like anaerobic, as I have told, metronidazole and metronidazole has to be added. Then this is a case scenario, 36-year-old male undertaken laminectomy of 4/5 vertebra. She had been suffering from spondyloradiculitis. After 5 days of discharge from hospital, she is again admitted to hospital, fever, chill, headache, vomiting and CSF leak from the vertebral wound, and vitals are stable, no neurodeficit, no papilloma, patient are conscious, but neck stiffness was present. So this is a case of nosocomial infection, meningitis, where you have to start with either ceftazidime, meropenem or meropenem plus vancomycin. Now, this is the CSF study of the patient. Glucose you can see low, protein is high, cell count, and gram-positive cocci. So this is a case of pyogenic meningitis due to neurosurgical intervention. Then another 40-year-old male was admitted to a rural hospital with a history of fever 7 days duration and was treated with ceftriaxone, became progressively drowsy and was shifted to our hospital. After 5 days of treatment, is non-diabetic, is no history of convulsion, vital stable, GCS 12, without any focal or neurodeficit, no papilloma, neck stiffness present, and this is a very common scenario in our practice. What do we think from here? Is it a case of partially treated pyogenic meningitis? Is it TBM, or it is fungal meningitis, or it is viral meningitis? See, the patient has only been treated with ceftriaxone. Vancomycin had not been added. So we see their opening pressure is high, yellowish, glucose 30, RBS 120, protein 180, cell count is 120, and it is 70% lymphocyte, gram stain, AB stain negative, and I should say that even in tubercular meningitis, only in 10 to 15% cases only in AB is producible in gram stain. In some studies, it's 10 to 40%. And coming to ADA, there is lots of controversy. I was going to the literature. The cutoff is 10. But their sensitivity varies from 44 to 90%, and on Nepali study, their sensitivity 83%, specificity is 90%. Again, when they have showed that this ADA can be raised in other meningitis like carcinomatous meningitis and some viral meningitis also. Then coming to TB bacteria culture, again takes time. Only 50, you can produce the bacteria only in 50%. Then coming to gene expert. So the PCR. The gene expert, they have got two types of gene expert. One is gene expert RIF, and another is gene expert ultra. The sensitivity of gene expert RIF is 83%, 60%, and specificity is 90%, whereas the gene expert ultra, both are more than 90%, is as good as a brain biopsy. And of course, PCR is negative. Now, so as I have discussed, what is this? All this differential diagnosis. Now look at the CT scan. You can see extensive basal exudates. So this is a case of TBM. But you must remember that rarely in fungal meningitis also we may get basal exudates. Then what are the atypical presentation of tubercular meningitis? Acute meningitis like acute bacterial meningitis, 2 days, 3 days fever. Even you can get neutrophilic predominance CSF. It may mimic, you repeat the CSF after 7 days, you find lymphocytic predominance. Patient is not responding to your conventional antibiotic. Then patient presenting with psychological behavioral problems, especially in elderly. TBM presenting with multiple cranial palsy, TBM presenting with stroke. So spinal meningitis, patient is being treated by spinal surgeon because of radicular pains. Often it is thought that patient has Lyme's disease, but you do CSF, it is suggestive of TBM. Then TBM may present without meningeal signs in the extremes of age and in immunocompromised patients. Then another case, 26-year female with history of intense headache and vomiting for 2 days, admitted to the hospital with 2 episodes of convulsion. On examination, she was confused, 100 degree Fahrenheit temperature, pulse 80, temperature, BP is 180/100, papilloedema present, neck stiffness is noted, and DTR normal, bilateral plantar fracture. So this looks like meningitis. So this is a case of subarachnoid hemorrhage. We may get fever, we may get neck stiffness. This is a very close mimicker of meningitis. So don't go for LP here, do DSA. If there is second bleed, patient, the mortality is 66%. Then another 35 years old male with a history of fever for 2 months, weight loss, lethargy, admitted to hospital with acute confidence state, positive meningeal sign, no focal neurodeficit, no papilledema, CT brain was normal. You see high opening pressure, and it's clear, protein 80, cell 100, lymphocytic predominance, and AFB gram state negative. Here we found Indian ink preparation for cryptococcus, and CSF cryptococcus antigen is actually not required. If you get antigen is only needed when you are not getting anything in your microscopy. So the patient is HIV reactive. So this is the diagnosis is HIV with cryptococcal meningitis. So this is the classical picture. Then this is a patient with tetralogy of Fallot, 16 years old, had underwent BT shunt, and the patient had been again admitted with history of fever, headache, and patient was having her plantar reflex were extensor, and we did this CT scan. This is classical of brain abscess, and patient had vegetation in VSD, ventricular septal defect. So encephalitis is defined as a reduced consciousness and encephalopathy with evidence of inflammation of brain parenchyma, which is often caused by virus. This term comes from Greek encephalon, meaning brain. So there is direct invasion of the pathogens within the brain parenchyma. So there are a big list of it. I have taken only those relevant of our context, Indian context. You can see the HSV JE occurs is a encephalitis. Our country bears a mortality of around 50 to 80%. Then you can see TB, rickettsia, brucella, spirochetes, limes. Malaria is important among the parasite, and other fungal disease has to be considered when we see the patient, immunocompromised patient. The symptoms: reduction of consciousness, subtle changes in behavior to confusion, disorientation, speech disturbance, lethargy, drowsiness, deep coma, sometimes mistakenly thought of a psychiatric illness, and symptoms of raised intracranial pressure. Severe headache and seizure can occur. Patient may have a preceding history of flu, malaise, flu-like symptoms like malaise, fatigue, nausea, etc. So why often encephalitis is missed? Because it is wrongly attributing fever with confusion to septic encephalopathy. And patient may not be febrile on admission. Ignoring patient's relatives' complaint that patient have some, regarding the consciousness, patient have some psychiatric change, recent psychiatric change or behavioral changes, and his GCS is 15. And wrongly attributing the clouding consciousness to drugs and toxins. Failure to properly investigate a patient with fever and seizure, following which they do not recover their consciousness. And failure to do LP, even if there is no contraindication, because we have been thinking it to be a case of septic encephalopathy. The 25-year-old non-diabetic male admitted with history of fever 5 days, 1 episode of GTCS confusional state. On examination, pallor, icterus present, GCS 8, no meningeal signs, BP 110/70, pulse 120, CBG is 28, which is corrected with dextrose. So this is a case of encephalitis with hypoglycemia, and his MPDA is positive. So MPDA can be done in emergency itself, and we can cleanse the diagnosis in emergency itself that the patient has falciparum malaria and start with artesunate immediately. Then 20 years old male, history of acute flu-like illness, after 6 days developed high grade of fever, headache, vomiting with confusional stage, GCS 10, papilledema absent. There is no focal neurodeficit and meningeal signs, and CT brain is normal. So it is an encephalitis-like presentation of acute onset, high opening pressure, crystal clear color of the CSF, protein 50, marginally raised, sugar normal, and cell 25 and 90% lymphocyte. So it can be TB, fungal or viral, but it started with flu-like symptom, most likely it's a viral. So gram stain, AB stain, Indian preparation not detected, gene export not detected, PCR study for HIV is positive. So it's and you can see the classical picture in MRI. This is the temporofrontal bone. This is a FLAIR image. Then nowadays we have got biosphere panels for CSF study. We can get the results within 1 hour. So we can do LP, and you can see the bacteria, virus and fungus within 1 hour you can cleanse the diagnosis and you can start the specific treatment. You don't have to treat a meningoencephalitis with antibiotic. What is acute encephalitis syndrome? This is a syndrome which has been coined by Ministry of Health and Family Welfare. It's clinically a case of AES is defined as a person of any age at any time of year with acute onset of fever and change in mental status, including symptoms of confusion, disorientation, irritability to talk, and or new onset seizure, excluding febrile seizure. And other clinical finding may include an increase in irritability, somnolence, or abnormal behavior greater than that seen in usual febrile illness. Then, as Japanese encephalitis is prevalent in a country, they have basically made an algorithm where they have found a suspected case with one of the following markers. When a patient has symptoms of encephalitis and presence of IgM serum and CSF specific virus of JE or enterovirus or other virus, fourfold difference in IgG titer in paired samples, and virus isolation in brain, and antigen detection by IF and PCR. Any one of the following with the symptoms of encephalitis. And probable case, suspected cases in close geographical and temporal lenses. I am to show the next slide and you can understand. So this is a suspected JE. So when adequate blood specimens can be found, after taking adequate blood samples, we go for IgM, CSF. Then IgM is positive, confirm JE, IgM negative. So we can send the panel. If we get any other infections, then it is AES, other agents, and sometimes we fail to get any virus or any infections, then it is AES unknown. And when we are not able to get adequate amount of blood or CSF specimen, then we have to look for where it has occurred. If it has occurred in those areas where there is epidemic of JE, and there is some laboratory confirmed cases, then it is probable JE. And if it is occurring as a sporadic case, then it is AES unknown. Then 35 years old male with history of fever, erythematous rash, skin rash over body and limbs, arthralgia, small and large and 5 days duration, attended year, and BP is 90/60, pulse 120. After admission, patient had high. This is a patient was admitted under us. And the patient was otherwise doing well. Then patient had a high spike of fever in the evening, or 107, and series of convulsion, put on ventilated. And then this was the blood picture, hemoglobin 10.8, TC a bit less, 80,000 platelet, MPDR absent, and dengue NS1 was reactive. So this is a case of dengue encephalitis. The MRI brain shows, you can see that in FLAIR images, bilateral symmetrical hyperintense intensities in thalami, pons, and left temporal region, and DWI shows that restriction of diffusion. So this is a picture of dengue encephalitis. Also, you must remember, you can get this picture in West Nile fever encephalitis also. Then coming to a case scenario, Johan, 28 years, had history of fever with shortness of breath, myalgia. On February 10, his consciousness progressively deteriorated, and then we can see that his TC is a bit low. Patient had chest CT has showed bilateral GGO, ground glass opacities, RT-PCR is positive, meningeal signs positive, and bilateral plantar extensor, and ABG PaO2 by FiO2 ratio 240, CSF within normal. So this is the MRI, an axial MRI image of brain of 60-year-old male with COVID-19 presenting with disorientation, decreased alertness. A FLAIR image demonstrates diffuse confluent white matter hyperintensities with sparing of subcortical U fibers. And DWI shows corresponding restricted diffusion throughout with involvement of white matter. So this is a picture of COVID encephalitis. So It is a very busy site. I think you cannot get through. So the Liverpool algorithm for suspected encephalitis is found the features of encephalitis, disorientation, seizure, and all those things. If meningeal sign is present, it can be meningitis. If meningitis is not present, then we have to take the decision whether patient CT scan can be done or the LP can be done before. So if LP cannot be done, then we have to start with empirical and antibiotic and antivirals. And if the LP can be done, then you have to look for whether it's a normal LP. If it's a normal LP, then with the features of encephalitis, we have to start empirical antiviral. And if we find that patient has got the features of encephalitis with PCR panel positive, then there are some infections like HSV1, 2, and Epstein-Barr virus and herpes zoster virus, where also we can start with, where you have to start with acyclovir. And if there is bacterial meningitis, you have to start with appropriate antibiotic. So, and to end here with just this picture. So in COVID time, we had great lessons and found patients with mucormycosis, CN, neuromucor, presenting with painful proptosis, stroke, confusion, etc. And especially patients who are diabetic, uncontrolled diabetic, getting steroid. And when we see this picture, the MRI sequence shows hyperintense lesion with hyperintense periphery. So this is quite consistent with mucormycosis. So a take-home message, as CNS infection has high mortality, early diagnosis of the disease is important. Early institution of empirical antibiotic and antiviral is mandatory. Neuroimaging LP should be done judiciously. Patients who do not respond to antibiotic, look for some alternate diagnosis and complications of the disease, like brain abscess in the case of pyogenic meningitis. And AES is a notifiable disease. Thank you.
Thank you, sir. Any questions? Okay. So I would now like to call upon Dr. Bishwanath Patro, Senior Consultant Medicine, Ramakrishna Mission Seva Pratishthan, to felicitate Dr. Majumdar with a small token of appreciation. Thank you, sir. The next session is on management of urinary tract infection by Dr. Ujjal Kumar Chakraborty. Dr. Chakraborty is Associate Professor, General Medicine, VIMS. Sir, request you on the stage, please.
Good afternoon, everybody. After lunch, probably this is very difficult to make you concentrate on this. And it's a very difficult subject for me because this is very common and very well known to all of you. So I really don't know how much justice I'll do to give you some new information about this. Okay, I'll start with a case. It's a 23-year-old female complaining of dysuria frequency. She is non-pregnant, otherwise normal. Urine shows 10 to 12 pustules, and culture is positive for E. coli with a colony forming unit of 1000 per ml. So this is a very classic case. And how we make a proper diagnosis of this case, I'll come into those things. So in UTI or urinary tract infection, there are some syndromes. Now what are those syndromes? First, we must know what is an uncomplicated UTI and what is a complicated UTI. Uncomplicated UTI is an acute cystitis or pyelonephritis in a non-pregnant outpatient female. So the patient is not pregnant, can be managed on an OPD basis, without any anatomic abnormality, and who is not undergone any instrumentation in the urinary tract. So this is a classic uncomplicated cystitis or complicated pyelonephritis. Together we call it uncomplicated UTI. Then what is complicated UTI? Anything beyond this, which is not fitting into this definition, is a complicated UTI. That means any male patient, pregnant female, infants, patient who has got anatomic abnormalities like obstruction or any renal stone or congenital abnormality, they are all falling into the category of complicated UTI. Why you need to do this? Because uncomplicated UTIs can be managed on an OPD basis. Some uncomplicated UTI may be managed without doing any urine examination also. By looking, by having the history alone, you can manage those cases. I will come into those. Other UTI syndromes are asymptomatic bacteriuria, acute cystitis, acute pyelonephritis, and prostatitis. What are the risk factors? I will not go into all the detail, but remember one thing, UTI is pretty common in females. Prior UTI is a risk factor for another UTI. Sexual activity is strongly correlated with number of acute UTI, especially in female patients. More number of sexual encounter, you have more chances of having UTI. Male patient, they do not usually have UTI without any anatomic abnormality in the tract, urinary tract. BHP is very common, urethral strictures. In young children, especially in infants, vesicular reflux is one of the common thing. Male infant, you should always treat them as complicated UTI because they are associated with congenital abnormality of the urinary tract. Common organisms in our country, this is ICMR data of 2017. Most common are Enterobacter, the E. coli is most common. Second is Klebsiella. Others like Enterococcus, around 11% they have seen. Non-fermenting GNB like your Pseudomonas and Acinetobacter around 8%. Staph aureus is pretty uncommon. So these are the usual suspects in UTI. Another case I'm coming into, very often we come across this kind of scenario. 45-year-old male coming with a fever, leukocytosis, urine parcel is 1 to 2, but culture is positive. E. coli more than 10 to the 5 CFU per ml. So what do we make out of this thing? I'll just come into it. Now, while we investigate UTIs, there are a few things we need to understand. One, microscopy, urine microscopy is very important. 10 or more parcel per high power field in a centrifuged urine sample is a significant pyuria and is the most important finding to make a diagnosis of UTI. The other is dipstick leukocyte esterase test, or another is nitrate. They are another rapid test to diagnose UTI. Next will be, and the most important will be the urine culture. Now, I will talk in a little bit of detail about urine culture, because most often we make so many mistakes in taking and analyzing the urine culture report. Now, you can, it's the most useful test, and you should always collect it before giving the first dose of antibiotic. And usually we take a positive culture as more than 10 to the power 5 CFU per ml, but any colony count is significant in a symptomatic young patient. That means a patient who is having symptoms of UTI, there is significant pyuria and the culture is showing any number of colony count, that will be taken as significant number. Or a sample which has been taken by suprapubic aspiration, any growth is significant growth, because normally the bladder will contain sterile urine, it will not contain unsterile urine. So if you take the sample in a sterile way and if it grows any bacteria, that is significant. That we need to remember. There are many things that we or the paramedics, they usually don't follow. The sample size, 10 to 20 ml of urine, should be midstream clean catch urine, or it can be taken as a suprapubic aspiration, especially in young children. And aseptic single catheter, in and out red rubber catheterization to take a sample in a hospitalized patient. So these are the way how you can take the sample. Now, if any patient who has been hospitalized on urinary catheter or on a Foley's catheter, then how you take the sample? So there two things happen. If the catheter is less than 2 weeks old, what you need to do is clean the catheter with spirit, with alcohol, and draw the sample with a sterile needle and syringe. That is how you should take it. If the catheter is more than 2 weeks old, then you need to change the catheter, put a new catheter, and then take the sample as I have already told, clean and take the sample with a sterile needle and syringe. You should never take the sample from the urine collection bag, never. The other important thing, the storage and transport. The moment you take the sample should be transferred to the lab and the plating should be done within 1 hour. This is the ideal situation, but you can be rest assured this never happens, not 100 out of 100 times. It never happens. So why that is important? Because the urine by itself is a very good growth media. If you keep the urine in room temperature for 4 to 5 hours, the bacterial growth will be there and you will get a significant colony count. Even when the patient is not having a specific infection. So the plating should be done within 1 hour, and if you suspect that it's not going to happen within 1 hour, then this sample should be stored at 4 degrees Celsius for at maximum up to 8 hours. 6 to 8 hours is the maximum time when you can store the sample. Like if you are having a patient who's coming at say 2 a.m. in the morning, you want to give antibiotic. You take the sample, keep it in the fridge, start the antibiotic. In the morning, you send the sample to the lab. But if you keep it room temperature, send the sample in the morning, after keeping it in a room temperature, it will come as a false positive culture result. So we come back to a second scenario. This male, leukocyte disease, fever, urine pus cell is 1 to 2. 1 to 2 pus cell means this is not a significant pyuria. Culture is positive. Without significant pyuria means this is not UTI. For UTI, you have to have significant pyuria. So what may have happened in this case is a scenario where the sample has been taken, it was not plated within the stipulated time. So it's an improper sample handling and pre-analytical error. Other investigations that are needed in UTI are blood cultures, if you're thinking of bloodstream infection, septicemia, acute pyelonephritis, or complicated UTI. Imaging is required in few scenarios, like any complicated and recurrent UTI. And in all male patients in the first instance only, because as I told you, male patient will not have UTI without any anatomical abnormality. CECT can be done if you think of pyelonephritis, abscess, paranephric abscess. Now I'll come to few I'll come to those syndromes. First is asymptomatic bacteriuria. So here what you have, it is asymptomatic, that means the patient is not having any symptom, but urine is culture positive. And urine, although it is urine culture positive, pyuria can be there or it may not be there. It may or may not be there, but culture will be positive. Now ASB is defined by absence of symptoms and colony count of more than 10 to the power 5. Treatment of ASB is indicated only in 4 situations. Normally it is not indicated, but in 4 situations this is needed: in pregnancy, in patient undergoing urologic intervention, neutropenic patient, and transplant patient. Because if we treat ASB in a normal patient, it's not going to reduce the number of pyelonephritis in a normal patient. But these 4 situations, if you don't treat ASB, these patients will end up with pyelonephritis. That is why you need to treat ASB in these 4 conditions only. And treatment should always be done according to the antibiogram, because the patient has already come with a culture report, positive culture report. In catheter-associated ASB, they are mostly asymptomatic, and antibiotic therapy is usually not required. What is required? If possible, just remove the catheter. That's it. 33% will improve by its own. Second is acute cystitis. The patient will have typical symptoms of dysuria, frequency, suprapubic tenderness, may or may not have fever. There will always be significant pyuria, that is more than 10 pus cells per high-power field, culture will be positive. If you do an ultrasound, you might get thickened urinary bladder because of inflammation and edema. But the empiric treatment of acute cystitis is nitrofurantoin and single dose of fosfomycin. This is according to the ICMR guideline. There are alternate drugs also there, but you must always remember, if you are thinking of pyelonephritis, prostatitis or septicemia, nitrofurantoin and fosfomycin should be avoided. You go for some other drugs. We come back to our first case. This is the case. This is a typical case of acute, uncomplicated cystitis, as for our discussion. Next syndrome is acute pyelonephritis. Now these patients will have fever with chills, vomiting, flank pain, renal angle tenderness, hypotension, septicemia can be there, with or without those typical UTI symptoms. There will be significant pyuria, culture will be positive, and CECT will show some abnormalities. Now, the most easily and most commonly found abnormality is the fat stranding, you can see here, and renomegaly, the kidney is enlarged, and you can see the surrounding fats are edematous, and it's called a fat stranding. This is another case, pyelonephritis leading to renal abscess. Now, if you're treating a case of pyelonephritis and the patient is not responding, you should always think about renal abscess. Renal abscess will look like this, localized hypodense lesions. And one more thing, even if you have diagnosed a renal abscess, and if the patient is responding to your antibiotic therapy, this patient may not need any intervention. But if the patient is not responding to your antibiotic therapy, the proper antibiotic therapy, you should always take help of the urologic surgeon for intervention. This is one case, this patient is still with us. She has got crossed ectopic kidney. The right kidney is fused with the left one. You can see the pyelogram. Both the ureters are on the left side. So this is a case of complicated UTI. This patient is still with us. Another patient, this patient came few days back. It's a male patient. He had a huge left kidney. There was a PUJ obstruction. He was multiple interventions were done earlier. This patient came with pyelonephritis, improved, and we sent the patient back to the urologist. Empiric treatment for pyelonephritis is piperacillin tazobactam or ertapenem. Now, what is the duration of treatment? If it is uncomplicated pyelonephritis, you can treat them for 7 days, but complicated one should be treated for at least 14 days. For children coming with pyelonephritis, they are always complicated pyelonephritis. They should be treated for a prolonged time. 14 days is the duration. Any complicated UTI should be managed in the same line for a duration of 14 days. So you should treat all complicated UTI with piptas or ertapenem or any other carbapenems for a duration of 14 days. Prostatitis is another thing. They, apart from all the features of UTI, they will have urinary obstruction, pelvic pain or perineal pain. Recurrent UTI in a male patient, you think of chronic prostatitis. Here there will be pyuria, but prostatitis is one condition where you get sterile pyuria, means the culture may be negative. There will be significant pyuria without positive culture. So here you should have a expressed prostatic specimen or EPS. You send it for culture, that might give you the positivity. You can do imaging. Imaging will show peripheral edema in the prostate gland, and abscess can also be there. For empiric treatment of acute prostatitis, ertapenem is the drug of choice. Piptas and other carbapenems can be given, but the duration is 21 days. So prostate will take a much longer time to get treated. Now there are some special conditions. One is UTI and pregnancy. Now UTI and pregnancy is a pretty complicated one. It's a complicated UTI. And asymptomatic bacteria is also something that we should always seek and treat. That means we should always look for asymptomatic bacteria and treat them, because if you don't treat, that will lead to acute pyelonephritis with preterm delivery and low birth weight of the babies. Drugs that can be used in or during pregnancy are nitrofurantoin, beta-lactams, cephalosporins, and aminoglycosides. Drugs that should be avoided are sulfonamides, because they can cause teratogenicity if given in the first trimester, or can cause kernicterus in the baby if given in the last trimester. Fluoroquinolones can cause cartilage damage. And for ASB, the treatment duration is 4 to 7 days. Beta-lactams and cephalosporins are the drugs of choice in UTI, in pregnancy. The other one is COTI, or catheter-associated UTI. It is divided into two. It can be catheter-associated UTI. That means there is symptoms in a catheterized patient with a colony count of more than 10 to the power 3. That means 1000 colony. Symptoms present in a catheterized patient with a colony count of more than 1000 or 10 to the power 3. Catheter-associated asymptomatic bacteria, where there is no symptom and colony count is more than 10 to the power 5. These are the two divisions in catheter-associated UTI. Catheters, they provide a conduit for bacterial transport and nidus for growth, especially for the biofilm-associated bacteria like your Klebsiella and Acinetobacter. The presentation can be typical symptoms of UTI or fever, maybe sepsis, maybe leukocytosis, because these patients are already there in the hospital, in the ICU. So they might present with fever, sepsis, leukocytosis, or the typical symptoms of UTI. Now the treatment requires the change of catheter and antibiotics according to the antibiogram for 7 to 14 days, because you treat them like complicated UTI. To prevent COTI, you need to avoid unnecessary catheterization and removal of the catheter as soon as possible. Whenever it is not necessary, just remove them. Another one is candidiuria. Very often we get this, especially in ICU. The risk factors for candidiuria are indwelling catheters, ICU patients, diabetics, patients on broad-spectrum antibiotics. The presentation can vary from asymptomatic to pyelonephritis to sepsis. Removal of the catheter improves candidiuria in approximately 1/3 patients. High-risk patients are those who have neutropenia, clinical instability, low birth weight babies, and those undergoing urologic interventions. And treatment of choice of candidiuria is fluconazole, 200 to 400 milligram per day for 7 to 14 days, because fluconazole is one drug which is excreted very in a high concentration in urine. Other drugs like echinocandins and others, they are not excreted in urine, so those are not the drug of choice in candidiuria. So the drug of choice is fluconazole. If the candida is resistant to fluconazole, you can switch over to flucytosine or amphotericin B in a large dose. Now, there are some points to remember, or these are the take-home messages. The treatment of ASB or asymptomatic bacteria is indicated only in pregnancy, patients undergoing urologic intervention, neutropenia, and renal transplants. Acute uncomplicated cystitis can be managed empirically without an urine culture, or in fact, you can treat them without having a routine urine exam also. A young patient complaining of typical features of cystitis, they can be managed with empiric therapy only, without doing urine examination. But if it is happening repeatedly, you should do culture, you should image them just to rule out that nothing is wrong with them. Empiric treatment should be based on local local resistance pattern. Post-treatment urine cultures in asymptomatic patients are not indicated routinely, but it can be done in complicated UTI or in patients who had a complicated hospital stay. For those patients, you can go for a post-treatment urine culture just to be sure that you have cured the patient. UTIs in males are uncommon in the absence of obstructive pathology, so you should always do imaging study on the very first instance in male UTI patients. Imaging is needed for recurrent UTI, complicated UTI, male patients, and when pyelonephritis or abscesses are suspected. For acute pyelonephritis, there are 3 ways that it can be treated, and this is a guideline from ICMR. They have now come up with 3 modes of treatment. One is hospitalization and full treatment. The second one is outpatient parenteral antibiotic therapy fully. Third one is you start the treatment in the emergency room, give them the first dose of antibiotic, you resuscitate them and then discharge them to the home with parenteral IV antibiotic therapy. So these are 3 ways you can treat pyelonephritis. Of course, these are uncomplicated pyelonephritis. Complicated pyelonephritis should be hospitalized always. Antibiotics should be changed based on antibiogram as soon as they are available. IV antibiotics must be reviewed at 48 hours if the patient is responding, and if you have antibiogram where you have an oral medication to treat the infection, you change it to oral medication. No antibiotic treatment is required when there is presence of pus cell in urine along with negative culture results, or in those with asymptomatic bacteriuria. If pyuria persists for repeated times, then causes of sterile pyuria should be sought after. So this is my take-home message. So that's all. Thank you.
Thank you, sir. So any questions? Okay. So I would now like to call upon Dr. Professor Ashok Saha, ex-Dean VIMS, to felicitate Dr. Chakraborty with a small token of appreciation. Dr. Ashok Saraf, I'm sorry. Ex-Dean VIMS to felicitate Dr. Chakraborty with a small token of appreciation. Thank you, sirs. The next session is on management of sepsis due to intra-abdominal infections by Dr. Soumendra Haldar. He is assistant professor in the Department of Infectious Diseases and Advanced Microbiology at Calcutta School of Tropical Medicine and is also associated with Medica Super Specialty Hospital as a visiting consultant. Sir, request you on the stage, please.
Good afternoon to all, respected my teachers and my friends. So thanks to Tanmay sir and Prabuddha sir for giving me the opportunity. Thanks to Medica and Ramkrishna Shiva Pratishthan. So I will start my talk. Basically, it's very difficult to talk a huge topic like this within a span of 20 minutes. So what I have done, what clinical problems we face every day-to-day practice, and what is possible best solution about that. So I have tried to highlight few points regarding that. So first, regarding the management in a nutshell, basically it's a patient when presents with intra-abdominal infections, source control is the main thing which we should do. then empiric antibiotic therapy, then fluid support. So what I have done, source control is the part of the surgeons and they are most efficiently doing that thing. Fluid support and the other requirement of vasopressor and all these things part of intensivist. So mostly I will discuss regarding the empiric antibiotic therapy, which is in the middle row, and what are the factors which will help us to determine what are the factors, what empiric antibiotic we should use upfront, when should we escalate, and when we should de-escalate the antibiotics. So my topic will cover these fewer points. Like microbiologically source control and drainage, empiric antibiotic therapy, targeted therapy, duration. What is the recently 2019 the ICMR has published guidelines regarding the infections of all body parts. So what are the guidelines regarding about our population, which will be something different from the US and UK, because the ESBL, the gram negative organisms are not a problem of US UK. That is our own problem, so we have to face it. So regarding, if I go by the 2021 guidelines, so they have mentioned these infections as the intra-abdominal infections. It comprises of appendicitis, calculitis, cholangitis, abscess, peritonitis, all these things. And I have excluded the things which is like in the abdomen, like solid organ abscesses, like liver abscess, like splenic abscess, like different infections in the intestine, like tuberculosis, like typhoid, like other infections. And I have excluded pyelonephritis, which my previous speaker also described. So my topic, I will do some the discussion with some focused topics. So regarding the pathogenesis, most of the times a source of infection happens because of breach in intrinsic mucosal defense barrier and allows normal flora to inoculate in the abdominal cavity. And you have to find what is the source of the infection. Like if I am talking about a patient who is having subcolonic malignancy or has infections arising out of the happening in inflammatory bowel disease or some colonic perforation, that you have to think of coliforms, because that is the common that are the organisms which usually remain in the colon. But if you think of like organism which may be responsible for the like perforation in the upper part of the gut, or it's something like in CLD patients, if there is peritonitis, or there are these chances of organisms coming from the upper GI tract, then it is mostly gram positive aerobes and anaerobes, and to some extent it is also covers candida. So I will discuss one case. This is a very practical case. A 42 years old lady admitted with fever, vomiting and pain abdomen without having any comorbidities. His TLC was raised, CRP was high, CT abdomen revealed pus collection in the right pelvic region, and diagnostic lab revealed 1.5 liters of pus. So what you will do in this case? Started on antibiotics and upgraded later because initially he was not responding. Clinical condition worsened, re-laparotomy was done. Initially it was laparoscopic drainage of 1.5 liter, but after that patient was not improving. So sometimes there may be explorative laparotomy may be done, and after that they find the source of infection was the uterus, so they have done the hysterectomy. After that patient improved. So from this case it's very important, it's not only the antibiotics, you have to remove the source control also, which is very essential in certain cases. So now the question is, what antibiotics should be started first? It is ceftriaxone, is it BLBLI, is it carbapenem? So there are certain factors which will guide you. Like if the patient is very sick, if the patient is having some comorbidities, then you should first upfront start BLBLI or carbapenem. And another very strong point is, if your local prevalence of ELV organism is more than 10%, then you should not use ceftriaxone. You should use either BLBLI or carbapenem. So for that thing, you have to have your own antibiotic data, your organism data and susceptibility data. For that reason, it is very relevant. So what point I will try to, what are the measures that can be taken in all setups, like in government setup, in corporates, everywhere. Like if we just send the samples before starting antibiotics, then we will having our own organism, our own data, own susceptibility data, which will guide us regarding the empiric antibiotic therapy. Because whenever patient is coming to your hospital from community, you know the strains in the community, and if a patient is having some nosocomial infection from your hospital, then you will know what are the bugs in your hospital, what are the antibiotic susceptibility about. Then it is sometimes it is of very help to manage the case. So when the coverage is needed for Enterococcus as MRSA, that is very important. I will discuss later. And regarding the Candida, what are the factors that will guide us? Yes, you should give antifungal coverage. It is immunocompromised patients, perforated gastric ulcer. As I have mentioned, if it is the upper gut, then gram-positive anaerobes and the Candida. These are the main organisms. So perforated gastric ulcer, presence of malignancy, recurrent intravenous infections. What is about the duration of antibiotic therapy? It is 3 to 5 days versus 10 to 14 days. There are huge studies. Now the point is, if you are getting the organism, if the patient is absolutely clinically stable, you have removed the source of infection. 3 to 5 days is good enough. But if a patient is having sepsis requiring ionotropes, patient is in ICU, then probably the duration of therapy should be prolonged. If you are thinking it is an established case of bacteremia like Candida is there, then you have to give at least 2 weeks therapy. So regarding the organisms, virulence of the organisms and capacity to adapt in the new environment. So if I go by Western literature, they have isolated 2 organisms as the most commonest 2 causes as E. coli and bacteroids. Because why? Because bacteroids in a very low oxygen concentration, they are having the ability to survive. For that reason, they are the common organism. Whenever we are discussing about the pathogenesis of different organisms. So coliforms usually in the early sepsis like E. coli, Klebsiella, Pseudomonas, Proteus and Enterobacter. Streptococci, Enterococci is common, and regarding the anaerobes, Bacteroides, Fragilis, Clostridium, Peptostreptococcus. So regarding the anaerobic coverage of meropenem versus metrozil. So one question what we frequently encounter is meropenem is having a very good anaerobic coverage. Metrozil we are giving for the anaerobic coverage. So what is the difference between meropenem and metrozil? The only difference is certain bacteroid species are there which is not usually responsive to meropenem and responsive to metrozil. So if you are having a very complicated anaerobic infections when you are not sure about the bacteria, sure about the organism, and it may be bacteroids, it's better to give both meropenem plus metrozil plus de-escalate as early as possible when you are getting the organism. Perforation of proximal bowel I have discussed. Difficult to isolate different organisms. It's very difficult. Lies to what case I have discussed. We have sent the pus twice, but we are not able to get any organism from the pus. So we have to go clinically. Empiric antibiotic therapy timing, who are very critically ill should receive empiric antibiotic therapy as soon as possible, and who are not critically ill delaying antibiotic therapy until we have sent the blood culture. Because 2 things, one is the isolation of the organism. If you put the patient on antibiotics, there is reduced chances of getting the organism. How much less it is? After first dose it is almost 90%, if after 2 doses 70%, and after 2 days of antibiotic therapy goes down up to 60%. So it's very crucial. And regarding whether early versus late initiation of antibiotic therapy, yesterday in the panel discussions we also got some knowledge regarding when we can wait and when we should start antibiotic therapy very upfront. So regimens, regarding the empiric regimens for intra-abdominal infections include antimicrobial activity against Peptostreptococcus, coliforms and anaerobes. So if I am asking about the single agent which is having all these coverage, that is piptaz. So piptaz is a good agent to start as empirical therapy. So this is taken from the Western literature. I will mention later what is our ICMR guidelines. So empiric antibiotic regimen for low risk community acquired intra-abdominal infections in adults. If it is single agent, then it's piptaz, that is covered the anaerobes, it covered the aerobes. But mind it, piptaz is not having the coverage against MRSA. Both piptaz and meropenem, they do not cover MRSA very efficiently. So you need to add second agent if you are strongly thinking of MRSA. And if I think of combination therapy, it's cefazolin, cefuroxime, ceftriaxone, cefotaxime, anything plus metronidazole. So if I think about the empiric antibiotic regimen for healthcare associated intra-abdominal infections, then if it is single agent, then either it is imipenem, cilastatin or meropenem, doripenem or piptaz combination regimen as the previous one. But here we are using ampicillin or vancomycin because we are thinking of some gram-positive organisms. So it's different from the community acquired infections. But the problem with India is huge. At yesterday we have discussed, we do not having any regulatory authority to prevent the over the counter use of antibiotics. So we are residing in a country where there is no audit of most of the institutions. definitely some institutions are having their own audits regarding the antibiotics, but I can mention there are some institutes in India also, in like where from the pharmacy, if the pharmacy is providing some high-end antibiotics, so they are having one group and they put this information in the group, I am providing antibiotics to this patient, and the HIC team of that particular hospital will reevaluate how much it is needed. So antibiotic audit can to some extent prevent the spread of MDROs in different healthcare systems. So regarding the empiric antibiotic regimens for healthcare associated infections, these are the regimens. And when we should cover the Enterococcus species, these are the commonly present in intra-abdominal infections and often are not covered in the recommended empiric regimen. But I am telling you, if the patient is having some healthcare exposure, like the patient was previously admitted to a separate hospital, now she is coming to a tertiary care, then you should cover the Enterobacter. According to the recommendations from the Joint Surgical Infection Society and IDSA guidelines, it's not necessary unless it is either recovered from the blood or only isolate covered from the culture from the infected site. So although here you have to differentiate between colonization versus infection, which is very difficult, but I am telling you, if you are getting any organism in blood, please take care about that, specifically if the patient is having some immunocompromising factors. So like a patient is having some malignancy, some HIV or some primary immunodeficiency or some other sort like CKD, CLD patient is getting some steroids for different inflammatory diseases. So this is very important. Regarding Candida, so antifungal coverage is warranted. Patient growth of Candida from sterile site. What are the sterile site? Like from blood, from CSF, you have to give it. Fluconazole is appropriate for the Candida albicans. Echinocandins is appropriate for the fluconazole resistant Candida species. Like in India, from the different studies from the Delhi, they have shown the tropicalis is more common than albicans. Now we are facing the Candida glabrata, Candida krusei, and Candida auris. Candida auris is a huge problem. And problem with Candida auris is it is 40 to 50% sensitive to echinocandins. It is very much resistant to azoles and liposomal amphotericin B. Problem with echinocandins is, as my previous speaker said, that the CSF and the urine is having the least concentration of echinocandins. So it's very difficult. If the blood culture is positive, then its echinocandin will act in the blood. But if the source is the urine or the renal tract, then it's difficult to treat. What about the cervicis sepsis campaign 2016 recommendations is blood culture to be collected before initiation of the antibiotics, by which we can de-escalate the antibiotics. Initial administration of IV intravenous antimicrobials to be initiated within 1 hour after the admission if the patient is in very critical situation. Broad spectrum antibiotics or combination of antibiotics according to the possible organisms which is involved in the clinical illness. Antibiotic spectrum should be narrowed after the microbes have been isolated. There may be some repetitions of my speech because I think if you listen one line twice, for me, I will able to remember it for a prolonged period. And based on the clinical situation, de-escalation of antibiotics after the culture sensitivity report as soon as possible. This is the most important line. De-escalation is much more needed than empiric coverage, because if you like the last day Cyrus also mentioned, if you one day, what is the cost of one day ICU therapy in a corporate setup, and what is the cost of therapy of one day antibiotic. So if you can de-escalate the antibiotic, I think, and if you reduce the ICU stay, then probably it's more beneficial. If I think about the cost benefit ratio, it's more beneficial. So these are the risk factors that warrant the blood empiric antimicrobial coverage. These are some factors when we have to be very cautious, like age more than 70 years, medical comorbidity, immunocompromising conditions, severity of illness, I think I have discussed. So antimicrobial therapy for peritonitis, so this is mild, localized or diffuse, and according to the mild or moderate, you can use these agents. And it is diffuse peritonitis, you should use very rapidly you should start antibiotics, and these are the antibiotics we should use upfront. What about the duration of antibiotic therapy? For appropriate duration antibiotic therapy, I have discussed earlier 3 or 5 days versus 14 days. I have mentioned one STOP-IT trial where they have shown 4 days versus 8 days of antibiotic therapy in addition to source control, like intra-abdominal infection after adequate source control. So they have shown there is no significant difference in mortality. But it is absolutely your decision. It is your call. When the patient is absolutely clinically stable, then you can de-escalate or you can shorten the antibiotic therapy. What are the factors that usually determine? That is the host factor, disease, organism, severity of illness, source control, and community versus healthcare. This is the ICMR guidelines. It is everywhere. You can go through the net. These are the, if it is community acquired intraabdominal infections of mild to moderate, you can start cefoperazone sulbactam as first line. If it is healthcare in severe infection, you should use imipenem or meropenem. If it is healthcare associated, so imipenem, meropenem plus vancomycin. Infected necrosis or abscess, imipenem, celestine and vancomycin. So is there any role of biomarkers during the treatment decision? So CRP peaks between, this is the few information which you can use this information regarding your choice of antibiotics. Like CRP peaks usually between post-operative day 2 and 3 and declines to baseline on post-operative day 5. So if there is persistent elevation of CRP, so it indicates the septic complications. Few conditions have cutoff values, not all conditions, like if it's colorectal resection, cutoff value is 100 mg on day 5, and pancreatic surgery it is 140 for post-op day 4. Procalcitonin, what about the procalcitonin? Rather than single value, procalcitonin clearance kinetics is more important. So how it's behaving, gradually if it is increasing, then you should think of infections. One, I can mention about the one trial, Captain trial, which have shown non-biomarkers including PCT discriminate between the SIRS and sepsis than CRP. Better than, it's not better than CRP. And PCT guidance can reduce the duration of antibiotic therapy and mortality. So PCT you can use for de-escalation, not to define infection. So management, I have started with these slides. Now case 2, I will very rapidly tell you regarding case 2. It's a very common situation. I think all of you have faced the situation. 54 years old male with decompensated alcoholic liver disease. They are having history of recurrent hospital admissions, presented with fever and swelling of abdomen, and the abdomen was tender. What antibiotics to be started? Patient developed hypotension after 8th day of empirical antibiotic therapy. So what to do? So now the spontaneous bacterial peritonitis. So it is the pathogenesis is translocation of bacteria of intestinal lumen, because you know in ascites there is increase in mucosal translocation is more because there is mucosal edema, and you know in cirrhosis there is qualitative and quantitative dysfunction of the neutrophils also. So they are to some extent immunocompromised patient. So ascitic fluid infection without recognizable source, that is the SBP. Commonly involved organisms are E. coli, Klebsiella, Staph aureus, Strepto. There are certain risk factors. Diagnosis, all of you know. And ascitic fluid culture and blood culture, you should send it before starting of antibiotics. And initial empirical antibiotics, start antibiotics, because you know if in SBP there cefotaxime is good enough. But I am telling you, if the patient is admitted of the healthcare or there is recurrent history of hospital admission, you should be cautious whether you should start you should start piptaz or meropenem for that SBP. Prophylaxis, is there any role of prophylaxis? Some in Western literature they have shown some prophylaxis with fluoroquinolones and Ceftriaxone. Indian literature they have not. It's not very efficient to prevent SBP according to the Indian literature. So these are the take-home message. Intraabdominal infections needs to be treated very promptly. Source control is to be done promptly. Source control, you know, there are certain points when there may be some clinical failure, like if you do not do the source control, like if a patient is having some deep-seated abscess, you are not able to remove it. In that case, you extend the duration of antibiotic therapy, but patient may not be cured. Second is, if there is some mucosal breach, if there is perforation, so you have to repair the thing. Otherwise, you are not you won't be able to treat it. Third thing is, be cautious about the thing that what samples you are sending, whether colonization versus infection. Like you have one organism has grown from a infected site or from a drain slide or a wound surface. One organism, and you are treating the organism with the effective drug, but the patient is not responding. This is one cause. This is one thing you are thinking that is the causative organism, but if the patient is not responding, please send another blood culture. Because sometimes these organisms, colonizers, may confuse you, and it effectively may prevent you to start early antibiotic therapy, proper antibiotic therapy rather. De-escalation to be done accordingly, which needs close clinical monitoring and optimum timing. Clinical samples to be sent before starting antibiotics. Antibiotics to be used rationally to prevent emergence of MDRO. Each hospital should have its own antibiotic policy for rational use of antibiotics. Like I am from School of Tropical Medicine, we are having 1 year data regarding the different kind of infections, what are the causative organisms and what are the sensitivity pattern. Based on that, we have started to make our own antibiotic policy. It will help us to guide our empiric antibiotic therapy. And I will finish by telling one story. When during my postdoctoralship, I have seen one patient where the patient presented with urinary tract obstruction, obstructive uropathy, and the patient was having an abdominal mass. So we have done the biopsy. First time the biopsy, we are thinking of some malignancy or tubercular mass, and subsequently everything was negative. Patient was not responding, and the mass gradually increased when the patient was on ATT, empirical ATT was started, as there was granuloma. So after 2 months of therapy, when the obstructive uropathy has progressed significantly, we have done the second biopsy, and second biopsy shown us the splendor Whipple phenomenon. So it was a case of basidiomyomycosis. This is a very uncommon case which presented with abdominal mass and obstructive uropathy. We have treated with the patient initially with, because it's a very resistant organism. So we have treated the patient with SSKI, saturated solution of potassium iodide, combination therapy with itraconazole. Initially few days with amphotericin B when we are not sure about it, and subsequently after almost 2 years of therapy, the patient is now absolutely fine. The mass just vanished. This is the beauty of the infectious disease. If you are able to diagnose the case properly, then you will be able to completely cure the patient. So you should think, if the patient, there are some atypical presentations of intra-abdominal infections, like these kind of presentations may present with actinomycosis. So these are the rare presentations. So I am telling last, but whenever you are getting one patient with intra-abdominal infection, think of all these things also, which usually help us to diagnose the patient. Lastly, I will all invite you to our annual conference with the Society of Tropical Medicine and Infectious Disease. Being the organizing secretary, I invite you all to our conference, on which will be held just the day after tomorrow, 12th of this month at Hotel Park. So thank you all.
Thank you, sir. Any questions? Okay. I would now like to call upon Dr. Prabuddha Mukherjee to felicitate Dr. Haldar with a small token of appreciation. Thank you, sirs. The last session for the day is on antibiotic treatment of chest infection by Dr. Amrita Bhattacharya. Dr. Bhattacharya is the unit in charge of the Respiratory Critical Care Unit, CM Kolkata. Ma'am, request you to be on stage, please.
Good evening. So this is the last talk for this workshop. I'm Dr. Amrita Bhattacharya, and as the organizer kindly said, I head the Respiratory Critical Care Unit at CMRI. I'll try to keep it very short. So we'll discuss a patient here. This is a gentleman who was recently admitted in our unit, a 72-year-old gentleman, diabetic, hypertensive, and CKD with twice-a-week requirement of hemodialysis through a fistula. He had presented with fever, shortness of breath for 5 days, and drowsiness for 1 day duration. Initially, he was treated with amoxiclav and azithromycin by his local practitioner. Now we all need to know how to treat this patient, because this is an ubiquitous patient. Everyone, whether you are sitting in a metropolitan city, where you're sitting in a peripheral center, you need to know about this patient. So this was his ABG at presentation. I don't know whether you can make out, but he was on around 4-liter oxygen when the ABG was taken, and he had a PO2 of 55. That's a lot of oxygen, actually. And SpO2 was 86% with 5-liter oxygen through face mask. He had a BP of 90/50, and he required low dose of noradrenaline. Respiratory rate was on the higher end, heart rate marginally high, and he was afebrile at presentation. So next, I'll show you the imaging. So if you can look, the left side, the X-ray, left side, we had prayed to God that there was some amount of volume overload, but unfortunately that wasn't the case. If you can see, even the right side is involved. That is not actually that evident on the X-ray, but the CT, it shows necrotic multilobar bilateral pneumonia. So then comes the question that we have been asked today, empirical antibiotics. Why is it important? So I thought I'd give you this data, which is actually significant for clinicians. So how many patients do you need to prescribe empirical appropriate antibiotics? Only 4. You prescribe appropriate empirical antibiotics for 4 patients and you save a life. That's how low it is, the number needed to treat. And I think you understand now how important it is. Now, what are the factors which tell us what should be the empirical antibiotic? So there are 3 subgroups. The first one, patient-related. So you have a list. Now, actually, most of these risk factors, they were introduced in the 2005 ATS guidelines, and they said that any patient who had such a risk factor would classify as something known as healthcare-associated pneumonia or HCAP. Now, subsequently, prospective studies have actually said that this is possibly too sensitive, that a criteria, what that means is that simply because your patient has been on home wound care, you should not escalate antibiotics. And this, in fact, had led to a lot of overuse of higher antibiotics, and hence, as of today, HCAP has been abandoned. However, you do need to keep all of these in mind when your patient presents. However, we have been told that there are certain things that you do need to keep in mind. That is, whether or not you need to give MRSA coverage and anti-pseudomonal coverage. It's not possible to remember a long list of factors at the bedside. What you should remember is that any previous isolation of MRSA or Pseudomonas is by far the most important factor which tells you that you need to cover those organisms. So when you're writing your discharge summaries, you need to mention what organism you have isolated, especially in centers like ours which have a lot of recurrent admissions. Now this is yet unpublished data from our center, around 4 months of data last year, 2022. As you can, this is about 150 patients who we had screened, and we had used a BioFire platform as well. Now what we got is that out of this 150 patients, 105 of the patients who we had suspected to have CAP or pneumonia had actually come back as BioFire positive, and only 16.3, that would translate to I think around 30 to 35 patients, were culture positive. That's how high the discrepancy was. There is a caveat to this, that many of the patients who had actually presented to our center had received outpatient antibiotic therapy. However, this is kind of the flora we got. Klebsiella was by far the majority, followed by Pseudomonas, Acinetobacter, and other organisms. So there were around 53 isolates of Klebsiella in those 4 months. When we further analyzed, so this is what we found. On the basis of the genetic markers, it was easy for us to classify it this way. And what we found was that by far the majority were ESBL producers, non-MBL carbapinamase, and the least was MBL carbapinamase. Okay? Only one strain out of all these 54 was pan-sensitive. So that was kind of an idea about my unit antibiogram. Moving on back to our patient. So when we went through our history of our patient, this is what we found. The red flags, we had antimicrobial therapy in the preceding 90 days. The patient had been on chronic dialysis, and he had also given a history that there was an infection in this old jugular HD site, which had been draining a little bit of pus. So we concluded that this patient has a high chance of resistant pathogens, including Pseudomonas, including staph. Now, we ended up giving our patient meropenem and teicoplanin, not a part of the regimen prescribed by the guidelines, but based on our data, our antimicrobial flora, that seemed to be the logical choice. So this is why you need your own data, because your flora is not going to be the same as what the guidelines say. If you go by what the guidelines say, this is the ATS guidelines 2019. So when you have a severe inpatient, generally the standard regime that is prescribed is a beta-lactam. So you don't have to give piperacillin tazobactam to everyone, because that is an anti-pseudomonal beta-lactam. You can get away with giving things like maybe ceftriaxone, ampicillin sulbactam, and you need to give a macrolide. Now, previously, they used to say that it's either a macrolide or a fluoroquinolone. Macrolide, currently, people say that, no, it trumps over fluoroquinolone, and especially in our setting with the impending risk of tuberculosis and a lot of C. diff. So, macrolide trumping over fluoroquinolone seems logical. If you have prior isolation of MRSA, you add an MRSA coverage. You add anti-pseudomonal coverage if it is so warranted. So, that is what they tell you. Some caveats, pleural infections. If you're suspecting a complicated pleural infection, you have to cover anaerobic infection, something like an empyema maybe. And if you need to know that intrapleural antibiotics are not recommended. And something else that I have found is very common, you do not need to give anaerobic coverage routinely in aspiration pneumonia unless it is a lung abscess. You do not. And please remember, when you're prescribing meropenem, meropenem has a good enough anaerobic coverage, almost as good as metronidazole. You do not need to give an extra anaerobic coverage. So anaerobic coverage, not mandatory. So there is sufficient evidence right now. You're giving oxygen, that is enough to kill your facultative anaerobes. Now, around 3 to 4 days later, this is what the culture report came back as. I don't know whether you can read this, but this is somewhat a colistin intermediate bug, and imipenem intermediate, MIC of 2, and everything else is resistant. So what did we treat him with? So we treated him with astronam and ceftazidime-avibactam. Now, the culture report says something, we are giving something else. Why is that? So in the recent days, there has been evidence, mostly observational studies, a few RCTs ongoing, that in case of NDM enterobacteriaceae, that is only colistin-sensitive enterobacteriaceae, not your non-fermenters like acinetose, pseudo, not them, enterobacteriaceae, you can get away with substituting astronam and a combination of astronam and ceftazidime-avibactam in place of polymyxins, and this in fact will help you. It will give you a colistin-sparing drug regimen, and also, surprisingly, so this is a very famous observational study, Falcone et al. They in fact showed that it gives you this combination of astronam and ceftazidime-avibactam. They showed it had a mortality benefit, leave alone treatment benefits and everything. So that is how useful they showed it to be. So only colistin-sensitive enterobacteriaceae, do consider this combination, but make sure that it's enterobacteriaceae. This is not valid for pseudomonas. This is not valid for acinetone. One more thing that you need to keep in mind for treating lung infections is your penetration. Most antibiotics that you are familiar with have a good enough lung penetration. Please remember that pleural space penetration of aminoglycosides, not that good. 2 antibiotics commonly used, tigecycline and daptomycin. Daptomycin will not act in the lungs, will be inactivated by your surfactants. Tigecycline, although sometimes we are forced to use it even in complicated lung infections, mostly due to Acinetobacter, tigecycline does not have a wonderful lung concentration. So maybe it's better to avoid both of these. So it's a balancing act, and initially you have to be as broad spectrum as possible depending on your patient, and you have to de-escalate fast. That is what antimicrobial stewardship tells you. So most people they will think that even if I isolate maybe a staph aureus on my sputum, कि कुछ gram negative coverage दे देते हैं, ICU में है patient after all. So that's not how it works. There has been enough studies to show that you are only left with the burden of adverse effects of the drugs. There is no additional benefit. And for some bugs, like staph aureus, so if you treat your methicillin sensitive, that is your sensitive staph aureus specimens, with something like vancomycin, you're actually causing harm. You need to give something like cloxacillin or flucloxacillin once you see that it's a sensitive bug. You're causing harm. There's an increase in mortality if you treat a sensitive strain of staph aureus with something like teicoplanin, vancomycin, linezolid. Antivirals, flu season again. So do not wait for confirmation. Start as soon as possible. The point that I need to make here is that, especially for not so sick patients, so this is not valid for the sick ICU intubated patient, the H1N1 influenza and influenza A, but this is valid for the outpatient and the semi-sick patients. After 48 hours, a maximum of 5 days, no role of antivirals. Timing of antibiotics en route, generally if your patient has severe enough cap to land up in the ICU, you need to give IV medications because you're not really that sure about the enteral administration. And timing of antibiotics, most people say that 5 days of antibiotics is quite sufficient unless it's, of course, an FDR bug. Something else, if you remember, our patient had CKD. The one more thing that I've commonly encountered, please remember that the loading dose of the antibiotic does not depend on the creatinine. Even if your patient has a creatinine of 8 and is on maintenance hemodialysis, give him the entire dose. Give him the entire dose of Astronam Zavicefta for at least 1 day. Then you can calculate your creat clearance and go down. But loading doesn't depend. And yes, once again, duration of antibiotics, 5 days of sensitive antibiotics and longer duration. For pneumonia complications like empyema maybe, necrotizing pneumonias such as the one we had, lung abscess, MDR bugs, but otherwise 5 days is good enough. That's all from my end. I promised I'd keep it very short.
This, we come to the end of the last session. May I now request Dr. Tanmay Banerjee to felicitate Dr. Bhattacharya with a small token of appreciation, please. Thank you, sir. Thank you, ma'am. With this, we come to the end of the 2 days workshop. May I now request Mr. Arnav Devgupta, co-founder and joint managing director, Medica Super Specialty Hospital, to deliver the vote of thanks.
Good evening, everyone. Not too many people left in the room, but I gather it was house full yesterday, 150 odd people, 63 hospitals. I think that's something to speak for. And I think the whole initiative of around rational use of antibiotics and the whole idea of making healthcare more affordable is very, very noble, and that's very important to look at. So from a point of view, from the government of West Bengal, WBCRC, and from everyone who's involved in it, to start off with Justice Ashim Banerjee and Mr. Arshad Warsi, I think their leadership has been really important for the state to take such a lead. And this is probably not only in Bengal, the entire country is looking up to how this thing is shaping up. And in partnership with the private sector that we're looking today would make a lot of difference in how we take more ethical healthcare forward to the whole country and become an example for the rest of the country. I would also like to thank Professor Sukumar Mukherjee. I think he just left. But I heard he was very unwell. He just got out of the hospital, but 2 full days he spent here. I think that's significant, shows the kind of importance that is accorded to a program like this. Dr. Tanmay Banerjee and Dr. Prabodha Mukherjee, who actually kind of detailed out the whole thing and ensured it got executed. Thank you, everyone. I think I must also thank, very importantly, the team from Ramakrishna Seva Pratishthan who actually helped in executing this, and my own team back from Medica who are actually backstage there. All of them, they had a great job. We'll see more of these going forward. Thank you very much. Thank you. Thank you. A small plant for you. This is very interesting. Thank you. And your plant. Thank you, everyone.